A 55-year-old presented with an ambulance. Came in via an ambulance with respiratory distress. Presented with respiratory distress, and this guy had chest pain since morning. Paramedics attempted to start an IV line, but he was really agitated. So he was really trying to climb off the trolley, and we weren't able to get the mask in place, the non-rebreathe mask in place. Okay, so you could see that this gentleman had a threatened airway because of severe, and he was in severe respiratory distress. He had extensive crepitations. He had threatened airway because he was uptended because of his hypoxia. The SATs at best were 90 on NRBM. Yeah, so it was not just the hypoxia, it was also the hypoxia. Shock often leads to agitation early. Subsequently, they become completely uptended, comatose. Yeah, so this chap was displaying all of that. His heart rate was 180, BP of 70/40, and GCS was only 13. Yeah, so he did not have any pedal edema. So this was the guy. So he's 55. Yeah, so with no comorbidities. The only presenting complaint was he had chest pain in the morning and he was now agitated and appeared breathless. He was tachypneic at 40. So this is the ECG. So as you all can see, this is a broad complex tachycardia. So this guy had a broad complex tachy, and with the background of no comorbid conditions. So we were forced to think that he was having an acute coronary event. So he had a synchronized cardioversion. So because this had to be sorted out. This is thankfully still perfusing. This is a VT, broad complex tachy, a ventricular tachycardia. And we could see that he was hypotensive with it. He was hypoxic because of the fluid overload from it. So he had all signs of instability. You name it, he had it. So, but we don't know if it was a chicken or egg. Was it an MI that provoked this, or this provoked an MI? We'll have to presume it was a MI that provoked it. So the first thing we did was we gave him a synchronized cardioversion. So the challenge here is to safely sedate these guys to have the cardioversion. So he's already hypotensive. You can't give him fluids because he's already in overt failure. So we had to carefully give him a touch of ketamine, and he was cardioverted. Synchronized cardioversion was done, and no surprises there. You can see that he's having a MI. So he's got real pronounced ST elevation in both anterior and lateral leads. He's having an anterolateral MI with reciprocal changes in 2, 3, and AVF. His EF was only 35. So it's probably not the best time to look at his ejection fraction because the myocardium is still stunned from the insult. So, but nevertheless, we could see that his LV wasn't contracting well, and significantly his anterior wall. So this guy had NORAD infusion. So he was intubated with etomidate because during an MI, we are not, it's not advisable to use ketamine. Only one situation where I would be reluctant to use ketamine is when we do know that they have an MI. So he was intubated with etomidate and sucks. He was given push doses of phenylephrine to bring his blood pressure up, and we placed an art line. His opening BP was 80/50. So can this guy be started on adrenaline infusion? Is there any other inotrope that we could be started off? Remember here, the shock, the cardiogenic shock, this will be labeled as a cardiogenic shock because the LV isn't contracting well. A sizable amount of his LV is infarcted, meaning it's become dead and it's going to be fibrous eventually if you don't do anything about it. So the contractility suffers. So you can give an inotrope, you can start a pressor, but they may not be able to compensate adequately. What do you need to do? You need to reperfuse this MI. So that will be the best way to treat this shock. So he was sent soon to the cath lab, high flow oxygen. He was intubated. We optimized the FiO2. He was sent on NORAD and adrenaline, and he had a proximal LAD which was stented. And subsequently, the guy improved. They may even consider intra-aortic balloon pump for a short period of time till the LV recovers. So you can only use a IABP as a stopgap when you know the LV is going to recover, and you can infuse all these supports, NORAD and adrenaline, and reperfuse, and hope his physiology takes over, his heart takes over. So which thankfully happened in this guy. He didn't need a IABP. Yeah. So that is how you would manage a cardiogenic shock. You can't give fluids. Fluids would have killed him. You may want to optimize intravascular volume, but this guy was already in overt failure. So no fluids. Remember, earlier on I did say fluids are not the answers for all hypotension. Fluids are not the only treatment for all shocks. Yeah. So this is a classic example of how you would want to deal with this patient. Yeah.